Medurstand. Understanding Medicine.
Hi, Professor Aziz Rehman here from Medurstand. We are covering Introduction to Clinical Method these days, and this is part 7. We have covered history taking, physical examination, general physical examination, and examination of respiratory system, cardiovascular system, gastrointestinal system, and today we're going to cover central nervous system. This is admittedly the longest and perhaps the most difficult. And in any system, it is important to know the basics, but I think it is particularly important in CNS because it has got altogether different science behind it. So I think you need to go through your anatomy and physiology before you can attempt to understand these physical science. Of course, I cannot go into the details of everything because if I do, then this lecture will never end. So very briefly, I'm going to remind you of some basic facts of anatomy. In central nervous system, we have brain itself, which consists of cerebrum, 2 of them, and cerebellum, basal ganglia, brainstem, pons, medulla oblongata, and then finally spinal cord. It has been divided into different portions, but it has got one uniform function. They all work together. Then we have a network of peripheral nerves starting from the cranial nerves and then the somatic nerves. Most nerves are both sensory and motor, but there are some pure sensory or pure motor nerves. And then we have another system called autonomic nervous system, and this is actually a blessing. Many of our brain functions, they are going on without even our knowledge. They are keeping us alive and up and running. So this is autonomic nervous system, which is further divided into sympathetic and parasympathetic nervous system. First of all, let's have a very brief review of a motor system. The motor system, of course, is the system which controls our movement, the skeletal movements, the muscle movement, and the center lies in the motor cortex on both sides in the parietal lobes, and there is a portion which represent our body, ups and down, and these are called upper motor neurons, and they have these axons coming through down and then passing through different parts, and then the brainstem and pons and then medulla oblongata. And most fibers, they go to the other side. We call it decussation. The fibers go to the other side and they make lateral corticospinal tract, and some fibers continue on the same side. They make anterior corticospinal tracts. So these will actually end up on the lower motor neurons, and lower motor neurons, they actually supply the muscles. Upper motor neurons, they keep lower motor neurons mostly inhibited to keep their tone low, but most of the sophisticated movement like writing, signing, making a drawing, or any sophisticated movement are actually started from the motor cortex, and they are executed through our lower motor neurons. And the problem could be here. If there is any problem from this part to this level, we call it upper motor neuron lesion, and it has got certain neurological signs which we'll discuss later. And if the problem is in the lower motor neuron or the fibers, then the nature of the abnormality will be different. That is called lower motor neuron lesion. Depending upon what is causing, it may be trauma, it may be a vascular event, it may be infection, it may be tumor, it may be some other injury. The nature of signs would be same, and they will depend on actually which part of the nervous system is affected. So that is why you need to know this exactly. If you see some abnormality, and only if you know this system, you will be able to localize the disease, which is the first point in the diagnosis of any neurological disorder. Again, very briefly, there is similar sensory system. Let's start from here. There are various types of nerve endings in the body. There are fibers which sense temperature, others sense pressure, other sense this pain, and some test the position, and they all pass through different parts. They come to the spinal cord through the posterior limb of this nerve and then pass upward, and then they end up in the sensory cortex. There are some sensations which can be perceived here also, but fine sensations like two-point discrimination, stereognosis, and the ability to appreciate the texture, to recognize things, they're all done in the cerebral cortex. So cerebral cortex is actually the master of all neurological activities. Then we have a network of nerves. We have first cranial nerves, and there are 12 in number. First is olfactory, which is involved in olfaction, the sensation of smell. Then we have optic nerve, which is extremely crucial for vision, and these two are actually cortical nerves. Then we have third nerve, and remember, all these nerves are bilateral. There is no exception. All cranial nerves are bilateral. They have bilateral, mostly unilateral innervation, but some upper motor neurons, they have bilateral innervation. Once their nerves go into the lower motor neuron, they actually have unilateral innervation. So olfactory and optic, and then we have oculomotor, which supplies our pupil, the upper lid, and eyeball muscles. Then fourth nerve, and then we have sixth nerve. So these third, fourth, and sixth nerves are actually many times discussed together, because all these three nerves, they control our extraocular muscles, and through that they control our eyeball movement. So very important. And then we have next in line is the seventh nerve on both sides. Then we have eighth nerve, ninth nerve, 10th nerve. There is a 10th nerve, and then 11th nerve, 12th nerve. So we have actually 12 nerves on both sides. They have different areas of supply, and they have different functions. Most are both sensory and motor, but some are pure motor, some are pure sensory. Some of the nerves which are important, I mean every nerve is important, but some of the ones which are important in the context of interpretation of certain neurological signs, and the ones which are usually asked in the examination. Now, one of them is facial nerve. Facial nerves comes out of the pons and then out of the skull through this small foramina, and then spreads out on the face, supplying the forehead and the eye lid, and then the facial muscles, and then the chin, and all these muscles, they are controlled by the facial nerve. Commonly, facial nerve can be paralyzed because of the pressure here ending, resulting in facial palsy. So we will have some slides on that also. This is trigeminal nerve. Trigeminal nerve is the fifth cranial nerve, and this comes out from the brain, and then it also has got three branches: the ophthalmic branch, and then trigeminal branch, maxillary branch, and mandibular branch. Actually, four branches. It also provides the sensation to the mucosa of the mouth, and it is particularly, and also the cornea, providing the basis of corneal reflex. Mostly sensory, but it has got a motor part also, which supplies muscles of mastication. But it is particularly famous or known for its associated disease called trigeminal neuralgia, which is a very, very distressing disease, a very, very severe pain, and depending upon which nerve is involved, you would have pain in that territory. Now let's, after going through very briefly, this is my disclaimer, extremely brief description of anatomy, and now let's have a overall scheme of examination. Like every system has a scheme of examination. Central nervous system also has got one, but it is different. You know, the other systems are inspection, palpation, percussion, and auscultation, but this is very, very different. So first of all, we assess higher mental function, including speech. Then we examine cranial nerves, all of them one by one on both sides. Then we come to the motor system. Motor system is the main system. We have different components of motor system and we examine all of them one by one on both sides. And then sensory system. Then we check reflexes, and there are various types of reflexes I will highlight in the subsequent slides. And then we specifically look for cerebellar signs, and finally other miscellaneous areas of nervous system like signs of meningeal irritation if you suspect meningitis or you suspect subarachnoid hemorrhage, or you may like to elicit straight leg raising test if you suspect sciatica or disc prolapse. Now, one statement here, if you examine the entire central nervous system in a methodology, in a proper way, it would take a lot of time. And there are people where that may not be necessary. Now, if somebody has a neurological symptom, of course, then it is mandatory to examine the entire central nervous system. It may take time. It may be very, very difficult also for the patient, because patient will have to cooperate throughout the examination. So it is a painstaking exercise, but it is worth it. If somebody has a neurological symptom, if somebody does not have a neurological symptom, then you will be quickly, I think, go through the main things which with experience we learn which test to be done and which to be skipped. Now, even if you have a central nervous system disease, I think you can have a targeted approach. Suppose somebody has a problem related to facial nerve, you can spend all your time in the evaluation of facial nerve and the related structure, and you can maybe skip some of the other parts of the central nervous system, because examining the entire central nervous system is very, very time consuming. And I must admit also, this exercise is now not done by many physicians, because many times we just pick up a neurological abnormality and we straight go for an imaging test, and that gives us a diagnosis. I think there is nothing wrong about that also, because if there is something available which can help us faster to reach a diagnosis, and a faster diagnosis would mean faster treatment and better outcomes, I think we must make good use of that. For example, if you suspect, if you have a case of stroke, I think an immediate MRI or CT scan would really be very, very helpful. Just brief neurological examination, very brief neurological interview, examination, and straight CT scan. I think that would not be a bad approach at all. Now, higher mental function, I will not be able to go into the detail. This actually we assess while we are talking to the patient. There are some specialized tests to assess memory and emotional status and orientation. That would be done only by neurologists. But here, during our history taking, we can tell if patient is oriented, if patient is fully awake and conscious and is not in severe pain. I think that we can assess. And during interview, we can also assess patient speech. Speech is an extremely important component of neurological assessment, and there are various abnormalities related to speech which we'll discuss in another video. And then we have specialized tests, like there are certain questionnaires and there are certain task-oriented tests which can be administered in some special cases. Then comes to cranial nerves. You know, we have different cranials. Let's see. First and second I have put together because they are both cranial, and first is usually skipped. Now let me admit that I think mostly it is not done unless patient has a symptom related to smell, anosmia. I think it may be tested. The basic technique is that you ask a patient to smell, to recognize some common smell, and that smell should be non-irritant, and patient should be blindfolded, and you should bring something near the nose one by one, and you should not touch the patient's skin and then ask him to recognize the smell. It should be something which patient can recognize easily. And second nerve consists, this is an optic nerve. You could check the field of vision, you could check the visual acuity, or for detailed evaluation, I think you could send the patient to your ophthalmologist colleague. And one good thing is examination of fundus with the fundoscope. I think you need to develop a habit, and you need to actually first learn the skill of examination of fundus. This gives you a lot of information, not only related to eye diseases, not only related to central nervous system, but also some systemic diseases like diabetes, like hypertension, like sickle cell disease. So it's a very, very important technique I think you need to learn. Then we have third nerve, fourth nerve, and sixth nerve. And I have put together three of them because they all control extraocular muscles. Also, the third nerve has got some additional function. Third nerve actually provides one limb of pupil reflex, the motor part, and it controls pupil, and it also controls upper lid, and then it is part of the extraocular muscles. Fourth one is just one muscle. Sixth is also just one lateral rectus muscle. So all three they work together when it comes to controlling extraocular muscle and the eyeball movement. It is extremely crucial because when we look at something, we focus on that, and that is done by these muscles and these nerves. And if they do not work properly, then we will not be able to see one object as one object, and there will be diplopia. So all these three are tested together by simple tests. I think you ask the patient that both eyes are tested one by one. First you cover, for example, if I'm testing the right eye, I will cover the left eye and ask the patient to follow my finger. While I'm looking at the eye, I move my finger in all different directions, right, left, up, down, and tangent this in the angle. So, and at the same time, I am actually looking at the patient's eyeball. Then I do the same on the opposite eye. Then we do when both eyes are open. So I think with that, when both eyes are open, that is where when we compare one eyeball with the other one. And also if one muscle is not working and in the direction which that muscle moves the eyeball, there would be diplopia. Patient would complain of double vision. And of course, we will have a test on that, and I will demonstrate the method. But here it is just, I think, enough to say you are looking at patient's eyes and see if the patient both eyeballs move in the same direction by the same degree. And you ask the patient if his or her vision has become double. In a normal healthy person, in all quadrants, no matter where you take your finger, patient follows the finger with both eyeballs moving in the same direction, and patient will continue to see one object as one object and crisp image. But if there is any third nerve palsy, fourth nerve palsy, or sixth nerve palsy, or there may be some additional problem like problem in the orbit, then there may be double vision. Then we have seventh cranial nerve. Seventh cranial nerve is very important because it is often involved in what we call Bell's palsy. Patient's nervous system, brain is okay because of some viral infection, some inflammation in the nerve, and the nerves get compressed and there is facial palsy. I think I'm going to show you that slide. Then fifth cranial nerves. I've listed, you may have noticed the sequence is different, and fifth I've listed separately because fifth is not very routinely tested except for the corneal reflex. And then 8th, 9th, 10th, 11th and 12th I'm going to skip here because they are they have overlapping function, and their tests are difficult, and I think I would consider them beyond the scope of this very basic lecture. They are important, of course, in some conditions they're very, very important, but I will have to skip them from here for further discussion. Now, some of the signs of these nerve involvement, and you just see pupil size. If this is the normal and this is much dilated, but at the same time you notice that there is no ptosis. So maybe this is just isolated. In third nerve palsy, there is dilated pupil and the upper lid also droops. But here the eyelids are okay, but just the pupil is dilated. Maybe when we dilate the pupil by putting a mediatic substance before we examine the eye, I think this patient is probably prepared for the examination. But you can see the difference, the pupil. Now here we see the paralysis of some of the extraocular muscles. In this case, you can see the patient is unable to open his or her right eye, and you can see the patient's eyebrow is a little elevated and there are some prominent corrugation. That means patient is actually trying, but it's not opening because the third nerve is paralyzed here. If you lift the lid, you will probably see that the pupil is dilated also if this patient has got complete third nerve paralysis. On this side, you can see, if you look at the eyes, this one is central and this one is medially deviated. And this eyeball, this cornea should be somewhere here in the center. I think I normally give the example of front wheels of a car. The front wheels of the car are controlled by steering wheels and they move in whichever direction, right or left, proportionately, so that both wheels are kept aligned all the time. So similarly, our eyeballs are kept aligned, but in this case, this eyeball has moved medially. Most probably because the muscle which is supposed to pull the eyeball laterally, the lateral rectus, is probably paralyzed. Maybe this person has got the left sixth nerve paralysis and the left lateral rectus muscle is paralyzed. Now this is the facial palsy, and you can see this boy has got somewhat asymmetric face, and you can see this left palpebral fissure is wider because patient is unable to close eye, and this side is flattened and this angle of mouth is pulled toward the right side. And if you ask the patient to blow, he will not be able to do so because this side is paralyzed. In seventh nerve, if one side is paralyzed, the structure will be pulled to the opposite side. In this case, it has been pulled to the right side. Patients sometimes feel, because this head looks somewhat deformed, patients sometimes tell us that this side is involved, but actually the side which is flattened, that side is affected. And this is a relatively mild case, and in some more cases, I think there would be much more pronounced abnormality. Now this was very, very brief about the cranial nerves, and then let's go to the motor system. In motor system, we check the gait. The moment patient approaches us, we see how the patient is moving, or patient is brought on stretcher or a wheelchair, or when patient moves to you, patient may have a specific gait. There are some specific gaits. I will not be able to go into the detail here, but you can tell what kind of neurological abnormality this patient is likely to have. So gait and then power, we formally check all muscles one by one and we compare with our own. Now, for example, I will ask a patient to flex his arm and will try to resist with mine and see if his power is okay. And we always do both sides, one after the other. Now, please remember, one basic principle of neurological examination is that you're mostly comparing one side with the other. Assuming that one side is normal, then you will be able to pick up the abnormality. Of course, there may be a situation where both sides are abnormal, but I think basically in most neurological disorder, one side is abnormal, and you compare the normal with the abnormal. And then there are various grades of power. Grade 5 is normal, and grade 0 is no movement at all. This will be discussed in clinical method video. Then tone, in a person whom you ask to relax and not resist, you should be able to move his body parts without any resistance. So there should be very when tone is very little, not sufficient to resist the movement. But in certain diseases, there may be increase in the tone, and there are diseases where there may be reduction in tone, and there are various patterns. Like you could have clasp knife rigidity, you could have the cogwheel type of rigidity, you could have lead pipe type of rigidity, and this will be discussed in subsequent videos. Then bulk of muscles. Now, depending upon one's overall build, you will compare the muscle bulk. Normally, our proximal muscles are better built than distal muscles. You should have a normal idea that in this person of this age, this gender, how much should be the muscle bulk. If muscle bulk is reduced, that would indicate lower motor neuron disease, and especially if there is one-sided involvement. If both-sided muscles are involved, this could still be a neurological disorder, but it could be some primary muscle disease, or it could be some metabolic disease or some systemic disease. Then many involuntary movements like simple tremor or chorea or athetosis or frank convulsions, all these would be noticed. Then come the sensory system. I think, in my opinion, sensory system is the most difficult, because here lots of patience is required, both on the part of physician as well as patient. Patient may be in pain. Patient may not be in a mood to cooperate. So I think you must respect patient's autonomy. If patient is in pain, patient is not willing to continue the examination, you may defer it for some other time. But sensory system is undoubtedly the most difficult one. So there are various sensations all over the body, from the head to toe. We test various sensation. Touch, we usually use cotton wool, and everybody with his eyes closed should be able to feel the touch and should be able to even tell what is touching his body and at which level, should be able to identify if right knee or left toe is being touched with cotton wool. And then pain, usually we test it with pinprick, but we could also use the pressure to assess the deep pain. Then temperature, we may have these test tubes with various temperatures, not too cold or too hot. Of course, like cold should be it should be like 1 to 10 degree, and hot may be 40 degree Celsius. So that can be, a patient should be asked to feel the temperature on all parts of the body. Vibration sense, this is very important, and you have a special tuning fork, and you vibrate it and put on different parts of the patient, the forehead, on the sternum, and on the alveoli, and see if the sensations are, if the vibration sense is intact. Now, this is not actually touch sensation. When you do this test, patient is asked to, if the person can feel that vibration. That vibration is different than the touch. Of course, you are touching the patient's body with tuning fork. That touch is different, and then patient may be able to hear those vibrations. That is also different. So you have to ask the patient if he or she can feel those vibrations. Then proprioception, normal person is able to tell the position of one's body part, and this comes from the special receptors in our joints, in our muscles, spindles, and deeper structure. So I think that is tested. Typically, patient's toe is moved upward and downward many times, and then positioned at one side and one point upward or downward, and patient is asked to tell if he can tell if it is upward or downward. And of course there could be one error, but if patient makes consistent errors, that would mean his proprioception is impaired. And there are other tests also. And then we have stereognosis, and this is, I think, the ultimate, the common object. If you give somebody a common object like a key and put it in hand and patient is blindfolded, patient should be able to identify that structure. And not only should be able to exactly identify, should be able to tell the texture also. He can differentiate a soft thing from a sharp thing, heavy from a light thing, and like that, rough from the fine things, and patient can recognize things. This is called stereognosis, and these sensations are actually cortical sensations. You need to have intact brain, the cerebrum, to be able to have these sensations positive. Then comes reflexes. The reflexes are an important part of examination. Even if you conduct a brief examination, I think some of the reflexes must be elicited, especially the tender reflexes, and especially in somebody who presents with paralysis. Now, deep tender reflexes, the philosophy of deep tender reflexes is that you strike on a tendon. There are some specific parts, and you need a hammer. You strike on that hammer, on that tendon, and in response, because when you strike that, there will be sudden stretch, and that stretch will stimulate stretch receptors in the muscle, and that through the spinal cord will come back as a motor signals for that muscle, and the muscle will contract. So there are various reflexes, like we have supinator, we have brachial, we have triceps reflex, we have deep tendon, this knee jerk and ankle jerks. Those should be tested on both sides. There is a jaw jerk also, but I think that is not routinely done. Only when somebody is having some neurological disorder, you are trying to differentiate between bulbar and pseudobulbar palsy, maybe then it would be needed. Then plantar reflexes. Now there is again a specific technique I will demonstrate in a separate video. Except for small children, the infants, every person, normal healthy person, should have a normal plantar flex. And when you make a movement, I mean you take a substance, an object which is not very sharp but not very blunt either, the back side of the hammer or the key, and you move it along the lateral border of the plantars of the foot, there should be flexion of the fingers, and there may be little withdrawal movement also, but that is normal. If there is, and the thumb should also move downward. Now if the thumb moves upward and there is a fanning out of fingers, that is called upgoing plantar reflex or Babinski sign, positive Babinski sign. That would indicate the presence of upper motor neuron lesion. Then abdominal reflexes, the superficial reflexes, you make a very fine movement with some things on the abdomen, and then in response abdominal muscle will contract. We move from outward, inward in 4 quadrants, and we see the movement. This sign may not be easy to elicit if somebody is very, very obese. I think in relatively skinny people, this sign is easy to elicit. And you have to be very gentle. You don't want to cause any injuries using the sharp object. Cremasteric reflex not routinely done, anal reflex not routinely done, and when you touch very gently the medial side of the thigh, there should be in a male person, I think both testes they get elevated, and then anal sphincter, if you touch around the anus, this anal sphincter contracts. So these are not routinely done. Only when you suspect spinal cord injury, I think then you can do these tests. Then we coming to towards the end of this presentation. I told you that I'm actually making it short because discussing all these things in detail would take a lot of time. In cerebellar science, cerebellum has got some special function. It is actually part of motor system, but it is primarily involved in coordination. We make movements, but cerebellum makes sure that the movement is appropriate as per instruction sent by the motor cortex. So if cerebellum, and cerebellum also has got two lobes, one side controls the opposite side. If there is problem with the cerebellum in the form of infarction or in the form of a tumor or in the form of degeneration, there could be different cerebellar signs. And these could be ataxia. Patient may not be able to walk properly, right? We as a human, we have developed this skill over evolution. We can walk straight. We can walk straight without holding on anything, without losing balance, and maybe we can actually talking to somebody else and looking in some other direction, still we can walk straight, and this is because of the cerebellum takes care of our gait. Then in nystagmus, eyeballs, there is a test, I think if there is cerebellar disease, eyeballs may make very jerky movement, and that will be covered in a separate video. We may have intention tremor. There are various types of tremors. One of them is intention tremor. That means when you try to approach something, and that is the time when your tremors get aggravated. This is called intention tremor, and this is a sign of cerebellar disease. Finger nose test and finger test and shin heel test, all these are tests of coordination, and we will be covering in separate videos. So we may have a problem with cerebellum, and where in other cases it may be a problem with the cerebrum or the spinal cord or the brainstem. Finally, in some cases where there is some problem, sign of meningeal irritation, this would be done in those where we suspect meningeal irritation. And two main causes of meningeal irritation include meningitis, which is still common in our country, unfortunately tuberculosis, or some other kind of meningitis, meningococcal meningitis, or it could be in people with subarachnoid hemorrhage. Signs of meningeal irritation may be positive. So what are those tests? One thing is, if patient is conscious oriented, you could just ask him or her to touch his shin with this sternum. Patient should be able to do it without any difficulty in a normal person. But if that is abnormal, that could indicate irritation. Then neck stiffness. Patient lies flat on his back. You ask the patient to relax and not to resist, and you try to lift the neck in a way and see how much resistance you face. In a normal person, there should be no significant resistance. Of course, you have to lift patient's head. There would be some weight, but you would appreciate that there is no actual resistance posed by the neck muscle. You lift the arm, and then you make the lateral movements also. In a typical case, the lateral movement should be okay, but only neck flexion faces resistance. That would be a sign of meningeal irritation. Then there is a sign called kerning sign. You first flex the leg at hip joint and then try to extend at knee joint. In a normal healthy person, you can extend the knee joint to almost straight, in a normal young person. But in patient with meningitis, you will not be able to extend the leg at knee joint easily, or patient will feel pain, or you would see that patient's neck is flexed, or you would see that you are unable to flex it because there's a lot of resistance. That is called kerning sign. So these signs are actually interpreted together to make a diagnosis of meningeal irritation. Then Brudzinski sign, this is little difficult. I think this is actually another expression of these two signs. If you flex the neck and if both legs also gets flexed automatically, reflexively, Brudzinski's leg, the neck flexion sign is positive. Now if you do the kerning on one side, the other legs get flexed, that is Brudzinski's leg flexion type is positive. This test is positive only when these two are positive, so this is often missed, actually skipped. Then straight leg raising test, when we suspect somebody having the lumbar disc prolapse impinging upon the long tracts, it is called sciatica. The pain starts from the lower back and radiates to the leg, and it's very severe excruciating pain. And if you ask the patient to keep the leg straight, in kerning sign we first flex at hip joint and then extend at knee joint. But in straight leg raising test, we just keep the leg flexed straight, and then the physician will lift the leg, making sure that it is kept straight, and then at a certain angle patient might feel pain. And this I will demonstrate, and this, if this is positive, that would mean that the sciatic nerve is getting impinged in the disc, in the spinal foramen. Now, making a diagnosis after going through the neurological examination, in a typical case you would go methodically, you would go systematically, but in some cases you would have targeted approach, a tailor-made approach. But then once you are done with the examination, you will have to make and present the diagnosis. I think there are three components of the diagnosis. One, where is the lesion? Is it in the cranium or is it in the spinal cord? In the cranium, is it in the cerebrum or cerebellum, brainstem, or where? Okay, so that is the number one question. Number two, nature of the lesion. What kind of lesion? Because you know, a specific part of the brain, if it is not functioning, it would produce the same signs. Now, what is the nature of lesion? Is it an inflammatory lesion or a neoplastic or ischemic or traumatic? That you would probably need further test and maybe history. Without history, you will not be able to reach the final diagnosis. Now, somebody coming with sudden onset right-sided paralysis, and then we have signs of upper motor neuron paralysis on the left side, on the right side, that would indicate that this is perhaps a case of stroke. Then secondary effects. Any brain lesion could cause secondary effects. For example, if there is a tumor in the cerebellopontine angle or somewhere, the tumor would produce certain signs because of its unique location, depending upon what function that particular part of the brain performs. There would be neurological signs, or there could be some secondary sign, because you know, skull has got a limited space. If there is a tumor, that takes space, and that is going to actually increase intracranial pressure, and there are some specific signs of raised intracranial pressure, so there you have to look for them also. So hopefully after going through this, you will be able to make a reasonable diagnosis. But let me admit, with the availability of this, we have become more complacent, and we are now relying more and more on these images. I don't think it is unfair, because if there is a facility which can tell us the diagnosis faster and more accurately, and can answer all the three questions which I posed earlier, so it can tell you the exact lesion, where is this lesion, what size, what is the nature of lesion, and if there are any secondary effects. Everything can be done with these techniques. So we have CT scan. CT scan It could be done with, it could be plain or with contrast. Contrast will give you better image quality, but would take additional resources and also pose the patient to the additional risk of contrast allergy. MRI is better, gives you more detailed information, but is more time consuming. So in acute situation, somebody coming with stroke, I would go for CT scan. And in a chronic condition, somebody coming with a motor disability, speech disability, or some gradual deterioration in mental function, I would go for MRI. And MRI again can be with contrast or without contrast. With the availability of these, the examination, CSF examination is now becoming less popular, and patient actually and the family usually hate this examination. And we also do not want to traumatize our patient unnecessarily, but there is one situation where CSF examination is absolutely mandatory. Despite the availability of these and many other techniques, CSF examination is absolutely mandatory when we suspect meningitis. Because in meningitis, the actual diagnosis will come from CSF examination, and we also want to know which organism is causing meningitis and to which antibiotic this organism will respond. So I think in that situation, CSF examination is must, and even in these patients, it must be preceded by CT scan because we have to rule out raised intracranial pressure before we go for CSF examination. With that, I'd like to conclude this presentation again saying this was relatively a quick and fast run through the scheme of examination of nervous system. Individual videos actually demonstrating the method will follow. This has been Professor Aziz Rehman from Medurstand. I really look forward to see you in my next video. Thank you very much and really appreciate your participation in my videos.